Since we've kept you here past 5, we had wanted to change gears and think a bit outside the box with the next talk and do something that's fun and a bit different. So we are delighted to have Dr. Ronnie Fass here. Ronnie is I'll say a bit of a hero within the esophageal field. He has published more than 450 papers at this point. He is also someone who is the world's expert in this particular area. He is editor-in-chief within Journal of Clinical Gastroenterology. He's the winner of the Janssen Award from the AGA, chief of GEI at Metro Health in Cleveland. He's also a professor as well at Case Western. So we are delighted to have him here. He is going to talk about sleep in the gastrointestinal tract. So I think something which is very relevant to all of us. But we're going to take a break for about 5 to 10 minutes and let everyone get some food and wine, and then come back and get set up, and then everyone can sip their wine casually while hearing about the possible effects upon gastrointestinal function and sleep.
First of all, I just want to mention that I'm a gastroenterologist. I'm not a sleep expert. But I did spend about 15 years of my career looking at the area of sleep, and that's why I thought that when John asked me to cover that topic, that would be a great one, because usually when you go to meetings, you hear about Lyon 2, Chicago 4, Rome 5. You're going to hear about sleep 1 today, because I think this is really outside of the usual talks that you're going to hear in big meetings. Now, I also asked John to change the topic because he wanted initially sleep in the GI tract, and I didn't want to keep you here till midnight. So I told him maybe we should focus on sleep and GERD, and we'll go from there. So I'd like to start in saying that probably many of you know that regular naps prevent old age, especially if you take them while driving. I'm sure many of you know that. But anyway, this is a paper that we did publish with Dr. Bill Orr in Lancet about 3 years ago about the effect of sleep on gastrointestinal functioning. And there's a lot of information here that if you want to expand in the area of the effect of sleep on the GI tract, you can get it from this paper. In addition, I participated in writing the chapter on sleep and gastrointestinal health in the sleep textbook. So this is not even a GI textbook, with David Johnson and 2 fellows that help us to write the chapter. So first of all, I want to just mention that you will all know that sleep is one of the 3 pillars of health. It's something that we start to recognize more and more in the last few decades. So we're all familiar with diet, exercise, and sleep. So if you want to make a difference in patients' life, it's not enough today to tell them, just change your diet. We really have to cover all these 3 pillars of health, which means diet, exercise, and obviously to change their sleep habits. Extremely important. Now, it's also very important to know, and I like to cite this study, that between 1960 to 2002, so over a period of 40 years, we lost on an average about 2 hours from our sleep. That means that if you look today, you'll find out that most of the population, the adult population in this country, sleep about 5 to 6 hours per night. So per definition, they fall under the category of sleep deprivation. Now remember, these people also go every day, they drive on the road. They work, they operate machinery, and they do a variety of other things. And I don't know if you want to be near somebody who operates heavy machinery while they're sleep deprived. 60% of the adult population. Now, being sleep deprived it doesn't come cheap. When you look at health-related consequences of sleep deprivation, and this is just a partial list. I mean, I didn't add here, for example, global warming, but it doesn't matter. But anyway, you can see that if you're sleep deprived, you're more likely to be involved in accidents, all the way from motor vehicle accidents, home-based accidents, accidents at work. You're more likely to develop a psychiatric disorder, memory impairment, dementia. There is a lot of evidence that if you're sleep deprived, you're more likely to develop obesity. You're more likely to develop diabetes, and the list goes on and on and on. I can't put everything here on this slide, but being sleep-deprived society does not come cheap. And you can see again, 60% of the adult population in this country is sleep-deprived. Okay, so let's now talk a little bit about GERD and sleep. So how common it is that patients with gastroesophageal reflux disease have GERD, have heartburn that awaken them from sleep during the night. There were many surveys that have been done, and they showed it's about 50%. So it's very common. Now, when you look at gastroesophageal reflux disease, most of the patients with gastroesophageal reflux disease have both daytime and nighttime symptoms. Only about 20% of them have daytime only, and very rarely they have only nighttime. So most of them have both, but half of them with nighttime symptoms here. Now, nighttime heartburn and its impact on sleep, you can see that 63%, this is from a survey, 63% of the patients said that it affected their ability to sleep well. 42% said that they were unable to sleep through a full night. 39% said that they had to take naps during the day. And 34% said that they were sleeping in a seated position. So you can see the impact of nighttime heartburn on patients' sleep experience. But more importantly is that 27% reported that their heartburn-induced sleep disturbances kept their spouses, their bed partners, from having good night's sleep. So the impact was not only on the patient, but it was also on their bed partners. Now, if you look at patients that failed treatment, like proton pump inhibitors, patient with gastroesophageal reflux disease, this survey found out, and others, that the most common breakthrough symptoms that this patient reported was during nighttime. And also, you can see in about 20% during sleep time. So when patients get breakthrough symptoms, those that do not respond fully to anti-reflux treatment in the form of PPI, then the most common time is nighttime. Now, this is a study that we've done. This was an NIH-funded study where we included 25,000 patients. And this is one of the papers that came from that study, and we looked at what factors affect reports of heartburn that awaken patients from sleep during the night. Now, that study was picked up by the news media, and I was even interviewed for Good Morning America. I'll let you figure out what the media was focused on, but it's not really that they focused on what I thought was important from this study. Well, we were interested to see the relationship between sleep abnormalities and patients' reports of heartburn that awaken them from sleep during the night. And you can see that if you have, for example, insomnia, you have twofold increased risk of reporting heartburn that awaken you from sleep during the night. If you snore or you feel sleepy the next day, the same twofold increased risk. What's interesting here that there is a 50% increased risk if you're taking benzodiazepines. Now, as you all know, benzodiazepine is one of the most common medications that patients take as a sleeping pill, like Halcion. It's a benzodiazepine, commonly taken, but it's associated with heartburn that awaken patients from sleep during the night. Now, guess what the media was focused on? The only thing they cared about is the carbonated beverages. The drinking soft drinks before, in the evening, that was associated with increased risk of developing heartburn that awaken you from sleep during the night. Now, studies have shown, and you look here, this is a study that was done by FRIM, that when you look at quality of life in patients with gastroesophageal reflux disease, then if you have nocturnal gastroesophageal reflux disease, you compare it to daytime gastroesophageal reflux disease and normal controls, those that have nocturnal GERD have the lowest quality of life. Because if it affects your sleep experience, it affects your quality of life. No question about that. Now, this is a study that we've done and included 41,000 subjects. And what we were able to show in this study, that when you took people that have gastroesophageal reflux disease versus those that don't have gastroesophageal reflux disease, that there is a twofold increased risk if you have GERD that you have some sleep difficulties. You have 75% increased risk to have problem with sleep induction, falling asleep. And then you have 89% increased risk of having problems in maintaining good sleep. Now, when you compare specifically GERD patient with nighttime versus those with daytime only, then you can see again that if you have nighttime, there is 53% increased risk of experiencing some type of sleep difficulties, 43% of having problems with sleep induction, and then 56% in maintaining sleep. There's also a clear impact that if you have nighttime GERD, here's a study that we've done looking at the frequent nocturnal symptoms versus no nocturnal symptoms at all. And if you have frequent nocturnal symptoms, then there is more impact on your work productivity. So it does also affect subjects' productivity at work. So why I'm focused so much on nocturnal GERD? Why it is so important from a GERD point of view? Beside, sleep disturbances, we talked about it. Well, when you look at patients with nighttime GERD, these are the patients that are more likely to develop erosive esophagitis, especially severe erosive esophagitis, grade C and D. These are the patients that are more likely to develop complications from gastroesophageal reflux disease, all the way from esophageal ulceration, peptic stricture, Barrett's esophagus. These are the patients that are more likely to develop extraesophageal manifestations of GERD, such as asthma, aspiration pneumonia, chronic cough. And these are the patients, of course, that are more likely to develop sleep deprivation. But these are also the patients that are more likely to develop adenocarcinoma of the esophagus. That's been shown also by many studies. So nighttime GERD or nocturnal GERD is literally the more malignant presentation of gastroesophageal reflux disease. So knowing all of it, at one point, maybe about 10 years ago, there was a movement to try and convince the FDA to approve, to make nighttime GERD as a separate indication for treatment. And several papers came out trying to convince the FDA. And this was one of them that was written by Bill Orr. And he said that nighttime heartburn and gastroesophageal reflux represent a distinct clinical entity which deserves specific attention in the diagnosis and optimal treatment of gastroesophageal reflux disease. And he was not the only one who was convinced. The only problem is the FDA was not convinced. And the FDA said no. From their point of view, there is no specific indication for nighttime GERD. There is specific indication for non-erosive reflux disease. There is a specific indication for erosive esophagitis. There is a specific indication for maintenance treatment, but not for nighttime GERD. However, there was one medication, I wonder if any one of you remember, that was indicated specifically for nighttime GERD. This medication is not with us anymore. It was removed from the market, but do you guys remember which one it was? It was just indicated for nighttime GERD, cisapride. And it's a medication that made tons of money. It's a prokinetic. It was not even an anti-secretory. And the only indication was nighttime GERD. So the next question is, why nighttime GERD is so different than daytime GERD? Well, during sleep time, there are alterations in esophageal function, okay? So for example, you can see that there is decrease in swallowing. When we are asleep, we don't swallow a lot. There's also a decrease to almost complete abolishment of salivary secretion. These are two important natural mechanisms against gastroesophageal reflux disease. The swallowing, it generates primary peristalsis that helps to clear the refluxate and also to deliver saliva that can neutralize the distal part of the esophagus. During sleep, there is also a decrease in upper esophageal sphincter basal pressure, potentially allowing for refluxate to traverse the upper esophageal sphincter and end up in the larynx, pharynx, and pulmonary system. There's loss of gravitational effect. Sleep is an altered state of consciousness, and as a result, there is decrease in conscious perception of intraesophageal stimuli. Now, if you lose the perception of these events, you're less likely to act upon them, unlike when you're awake. We talked about decrease in salivary delivery and in primary peristalsis, and as a result, increase in acid exposure time. There's also decrease in gastric emptying, which can also exacerbate reflux. And if you sleep in the right decubitus position, you're more likely to experience GERD than if you sleep in any other position. Now, one of the early studies that we've done, we looked at the distribution of acid exposure during sleep time in the esophagus, and we looked at patients with erosive esophagitis, non-erosive reflux disease, and patients with Barrett's esophagus. We divided the sleep period to 4 quartiles, the first 2 hours, second 2 hours, third, and fourth. And what we've noticed is that the acid exposure during sleep time is the same in all 3 phenotypes of GERD, except that in Barrett's esophagus it was much higher. But you can see the same distribution where it's higher during the first 2 quartiles, and then you see a major drop, and then it becomes really low in the third and fourth quartiles. Now that's very important from my point of view, because when you talk about MNBI today, and I'm not sure how many of you have heard about MNBI, but that is the average of baseline impedance at each channel over 10 minutes, and it's calculated at 1 o'clock, 2 o'clock, and 3 o'clock. Now, when you come with an MNBI number, you get the idea that maybe the MNBI, or the nocturnal baseline impedance, is about the same throughout the sleep period. But this is not the case. This is a study, for example, we just did and submitted for publication. You can clearly show that there is an inverse relationship between the acid exposure and MNBI throughout the sleep period. And it follows the same pattern that I've just shown you, where it's very high at the beginning of sleep, and then it drops towards the second half of sleep. The same thing will happen with the impedance. And so the impedance does not really stay the same. It moves. And this 1 o'clock, 2 o'clock, 3 o'clock has no meaning. What really has meaning is the period of time that you're asleep. Now, the other thing that we ask ourselves, you all know that the way we evaluate reflux testing today is based on what I call body position. We look at upright and recumbent. A lot of time we use the misnomer supine, but it should be upright and recumbent. This is how you're going to get results, body position. But really what matters is the change in physiology that we see during sleep period. And what we felt, it's what really matters is your state of consciousness when it comes to reflux. So you should check awake and asleep. So we did a little study, and we wanted to see if we are right or not. We looked at the 3 most important parameters when it comes from a reflux point of view: the frequency of the reflux events per hour, percent total time of pH less than 4, and the number of sensed reflux events per hour. And what we did, we took the upright period, We took the recumbent-asleep, where a patient is in recumbent position and is asleep, and then we took a period where you're recumbent and awake. Now, what is it, recumbent and awake? That you are lying on a sofa and watch TV. Okay, now you're recumbent and awake. And we said, if body position what matters, then what we see during the recumbent awake should be closer to recumbent asleep. If what we think, which is awake and asleep, then recumbent awake number should be close to upright. And as you could see, the recumbent awake, really the numbers close to the upright and not really to the recumbent asleep numbers, which look way, way lower, something you would expect. Suggesting that probably the way we should analyze reflux testing is based on awake and asleep and not on body position. We did then a series of studies using Actigraphy. Now, Actigraph is a watch-like device that you can wear on your non-dominant hand. And by movement by your movement of your head, it can determine if you're awake and asleep. It doesn't tell you what sleep stage you are, but it does tell us if you're awake or asleep. Let me show you what new things we learned from this device. Now, this is just to show you. This is a regular pH test. I mean, probably many of you don't see it anymore because you see only pH impedance and you see Bravo, but this is the old-fashioned pH probe test. And you can see that this is the green area is the sleep period the patient reported. Now, when you look at that period, you can see a few things. You can see, first of all, there are areas of reflux events here. You see it drops below the red line, okay? And then you see here, this is a place where the patient said that they had chest pain. This is all in this sleep period. But this is the information you get, and you don't get more information. Now, remember, when we did this study, we did it with the Actigraph that told them whenever the patient was awake or asleep. Okay, these are the things that I mentioned. Then that's what we found. So it gave us a lot of new information. So first of all, this is the period, the green here, where the patient had reflux. This is the time that the patient was recumbent and awake. So the patient was in bed, but was not asleep, reading a book, tweeting, Facebooking, whatever, what people do instead of falling asleep. Then the blue line is when the patient was asleep, the blue, and the patient fell asleep. And you can see that the patient had 2 periods where they woke up for between 20 to 25 minutes. And during that period of time, the patient refluxed. And during that period of time, the patient also reported chest pain. You cannot report chest pain if you're asleep, right? You have to be awake. So what we got from this information was that there was clear sleep fragmentation here, where a patient's sleep period was fragmented to 3 different types of sleep period. And when your sleep is fragmented, the next day, you're not going to be the happiest man on the face of the earth. You're likely to be cranky as could be. And that's part of it. But the other thing that we found out was the following, that here, that the recumbent period is a very vulnerable time, recumbent and awake, very vulnerable time for reflux to occur. So entering sleep, that period of time, patients may have more reflux. Then when you're asleep, less reflux. And then when you have reflux events, think about periods of awakening. Now, the other thing we learned from this technique was the following. You see here that there are 2 arrows, black arrows. This arrow shows you these reflux events here, which looks that it takes a long time for the patient to clear it, you see? And then you see another clear reflux events during an awakening period where the patient cleared it very quickly. It just comes down and goes up very quickly, where the other one, it goes down, and then it takes time to come up again. The reason for that is obviously that the longer time to clear was when the reflux occurred while the patient was asleep. And while you're asleep, you don't initiate your defense mechanisms. So you don't initiate swallowing, you don't initiate saliva production, and so it takes a long time to get rid of reflux. Not something that happened when you're awake. Now, during the awakening period, obviously the patient was awake, the patient was able to initiate all the defense mechanism, and the reflux occurred and relieved very quickly. Here is the reflux events during the sleep period. Takes time to clear it. Here is the reflux events that occur during the awakening period. Very short time to clear it. Now, the other thing is we look to see what happened during this recumbent-awake period, where the patient is in bed, but they're not asleep. And so we compared that period of time to immediately after when the patient fell asleep. And we were able to show that when you are recumbent and awake, then the number of acid reflux events that you will experience are going to be way higher than during the recumbent asleep that comes afterwards for the same period of time. The mean number of acid reflux events is much higher. The mean duration of acid reflux events, it's much shorter because you're awake. And then the percent reflux event associated with symptoms was much higher during the recumbent awake. Again, suggesting that entering sleep is a very vulnerable time for us from a reflux point of view. Now, that does have ramifications when we take care of patients, of course. I mean, that tells me a lot. What should I recommend patients when they go to bed? Here is an example of a patient. And you can see that this is the period the patient was awake and recumbent, the green area, and you see a lot of reflux. Then the patient fell asleep, and then the patient had an awakening. During the awakening, the patient experienced another reflux, and then the patient fell asleep for the rest of the night. Now, the other thing we wanted to know, does heartburn, that awakened patient from sleep during the night, is the most common manifestation of nighttime GERD. So we took patients and we found out that they have 104 awakenings from sleep during the night that were associated with reflux events, 104. And we found out that the percent of them that had symptoms with them was only 31.5%, suggesting, and that was very important, I think, from my point of view, especially when I see patients in clinic, most of the time, patient will wake up with reflux events during the night without symptoms. Remember that. The most common presentation from nighttime point of view in GERD patients is not heartburn, but rather the patient wakes up. No heartburn. Only in the minority, it will be associated with heartburn. So one of the questions you can ask your patient, do you wake up from sleep during the night, regardless if you have heartburn? Here is an example. This is patient reports, my chest was burning most of the night. And you can see why. The patient, the red is during the period of time where the patient was having heartburn. Pretty long period of time. But you can see why. The patient experienced at least 6 awakenings that range from 4 minutes to 38 minutes, and they were associated with a lot of reflux events. Now, most of the reflux events actually occur after the patient wakes up. That was very interesting, 88.2%. Only the minority of them occur before the patient woke up. The other thing is, obviously, if you wake up and then you have a reflux event, it takes shorter time to get rid of it, but if you don't wake up, it will take you longer time to get rid of that reflux event. And then we also found out that there's another phenomenon which we called it riser's reflux. Riser's reflux, and literally we called it, that was the name of the paper, an eye-opening experience. So when you wake up in the morning, GERD patients may experience riser's reflux. So when you look 1 hour before awakening, only 18% of them you were able to demonstrate reflux. 10 minutes after awakening, 33%. 20 minutes, 50%. So you wake up in a bang. After you wake up from sleep, transition to wake up in the morning is also a vulnerable time for reflux to occur. And this is an example. What about napping? Napping is a bad combination, of course, because we all know that people like to nap after big meals. The famous siesta is after you're having a very good lunch, then you nap. The other bad thing is napping is not associated with deep sleep. Studies have shown that deep sleep is associated with reduction in transient lower esophageal sphincter relaxation. It inhibits TLESR, which is the main mechanism behind gastroesophageal reflux disease, deep sleep. Now, here you are immediately after a meal, and you don't have the option of deep sleep, of inhibiting gastroesophageal reflux. So we looked into this, and we found out that when you compare napping to sleep time, napping was way markedly associated with gastroesophageal reflux as compared to sleep time. In fact, it was even worse as compared to daytime reflux. This is how bad it is. So napping after a big meal, if you have gastroesophageal reflux disease, not a good idea. Most of the reflux events we found out occur at stage 2 of sleep, small percentage of them during REM. Most of them, by the way, don't occur during awakening. Awakening is that you have to be awake, and it requires at least 2 minutes that you're awake. Most of them occur during short arousals, which were less than 30 seconds. Those tend to be amnestic. Patients don't remember them. You can experience 50, 60 of them during the night. You will not remember any of them the next day. However, they still cause sleep fragmentation. You will know about them because the next day you will be tired, exhausted, unable to concentrate, and you know what the consequences of that. So we came up with what we call the sleep and GERD model. So we did know that sleep altered esophageal physiology, and if you have GERD, it makes your GERD worse. Now, we did know that increase in GERD decreases your sleep quality. But what's about can sleep alteration in sleep quality by itself can increase gastroesophageal reflux disease? So that was our next question. So we can complete this bidirectional model between sleep and GERD. And we did this study. That study was done a while ago, where we took patients. These were patients and control, and we actually sleep deprived them 2 nights in a row, 4 hours only. And then they came to the motility lab. We put a tube inside their esophagus, and we perfused 0.1 normal hydrochloric acid into their esophagus. Then through a recovery period, then they crossed over to the other arm. The same thing we did with normal controls. And what we found out that if you're a patient, and we did also good sleep, which they had to sleep at least 8 hours 2 consecutive days before they came in. And when we found out that after bad sleep, patients demonstrated significant reduction in perception thresholds for pain. So their acid perfusion sensitivity score was very high. So it was very clear to us that poor sleep is hyperalgesic and good sleep was analgesic. The same effect you can see in normal controls. It's the same effect, but it was much less pronounced than in patients with gastroesophageal reflux disease. So one thing we learned is that if you sleep-deprived patient, you will lead to increase in esophageal hypersensitivity. But we did another study, which we published only about a few years ago, where we took normal subjects, healthy subjects. They don't have gastroesophageal reflux disease, and we did the same thing. We exposed them to good sleep, bad sleep. They were randomized to one, and then they had a recovery period, and then they crossed over to the other arm. And we were able to show that during bad sleep, we were able to increase the percentile time of acid exposure. Remember, these were normal subjects. In fact, we were able to convert about half of them to abnormal esophageal acid exposure just by exposing them to sleep deprivation. So knowing that, we came to the conclusion that we have a bidirectional relationship. And I'd like to finish here with a few slides. I don't have time to talk about the relationship between GERD and obstructive sleep apnea. That's another talk by itself. I'll be happy to answer any questions. I can tell you that there were a lot of hypotheses about this relationship. You can read them here. But at the end of the day, we believe today that the reason why the two are related, GERD and OSA, it's probably through a similar risk factor, which is obesity. So one way to improve, to break this vicious cycle is obviously to give these patients anti-reflux medication. You can break one of the arms. This is actually a study that we've done with dexlansoprazole. I was able to convince the company at the time to put together a study that looked not only at nighttime GERD, but also at sleep disturbances, and was able to show that if you treat patients with nighttime GERD and sleep disturbances, you can improve not only their nighttime reflux with dexlansoprazole, but you can also improve their sleep dysfunction. So we know that we can break this cycle there. The question is, of course, if I improve sleep, can I make GERD better? Just giving them sleep treatment. So we did the study, and this study actually, we gave patients Roseram. I don't know how many of you are familiar with Roseram. It's a sleeping pill, Ramelteon. They were randomized, they were non-erosive reflux disease patients. They were randomized to 8 milligram Roseram versus placebo for a period of 1 month, and we followed them. And we found out that we were able to improve their daytime and nighttime symptoms, but specifically more their nighttime symptoms. These patients were not getting any other medication. They were getting just a hypnotic, a sleeping pill. And we found out also that our main effect was on improving patients' insomnia. So that means we can break the two, this relationship at both arms, and obviously the next question, what about combination of both? That remains to be seen. Now, this is kind of an overall therapeutic option for patients with nocturnal GERD. Here, they're mentioned when you look at lifestyle modification, these are the typical lifestyle modification that we have, that we tell them, and these are based on data that we have. Elevating the head of the bed, sleeping on the left lateral position, and avoidance of late-night meals. You can see the medications. Most of them, we don't have data to support them. Most of the data comes from PPIs. There is data about hypnotics. I mentioned Roseram. There is data about melatonin. Melatonin can even decrease acid production. Some data on zolpidem, which is Ambien, that it does work. Reflux surgery and others. I think that based on some of the work we've done, we thought that should be more of it. We wrote this paper. This was published in Nature Reviews. And we wrote it, that was published 2 years ago, and we added the other important components of lifestyle modification, which is turn off the lights when you enter the bed, first thing. Then minimize the awake period before falling asleep. We have to get rid of this recumbent-awake period. And minimize disturbances during sleep time, good sleep hygiene, because good sleep, remember, good sleep is analgesic, and poor sleep is hyperalgesic. So make sure you have good sleep hygiene. I want to mention that because you have to know that the market, and I want to point out to 3 things that I think coming our way in relation to that area. First one, the web and GERD and sleep. I just chose Amazon Prime. When you put GERD there, you find pages about all kinds of equipment and devices and substances and potions to fix your, and in fact, we are now doing a study to see what they are selling there. But one of the areas that is very popular is really pillows and mattresses. Forget about the bed wedge. You know, in the old days, I would just say, go and find a bed wedge, or bedge called it. Now, go to Amazon Prime and choose your mattress of choice. Here, this is just one page where you can see a variety of pillows. I lost contact. Where is the guy?
Maybe you can use the arrow on the keyboard.
Oh, good point. No?
Yes, no.
Did I point to the neighbor's laptop or what?
Download a file. There we go.
Okay. So this is, for example, I don't know how many of you are familiar with the Medcline pillow. That was developed actually for pregnant women with severe reflux disease. It anchors you in the left decubitus position the whole night. If you don't mind to stay in the same position the whole night, that's a great pillow. The only thing, it costs about $265. It's not cheap. And how about the incline mattresses that keeps your torso about 45 degrees? It could be a cliffhanger for you during the night. You may find yourself at the bottom of the mattress. This is actually a review in the New England Journal of Medicine that I published 4 months ago. This is about the clinical practice of gastroesophageal reflux disease. And again, here I paid a lot of attention when I wrote about lifestyle measures about observe good sleep hygiene, because I think it's extremely important to emphasize that to our patient. Remember, heartburn is not going to be their main symptom when it comes to nighttime. It could be sleep disturbances and not necessarily any symptom. I just want to finish. This is another thing that I think many of you have seen this the bunch of publications that came out with the left device. This is a device that you put at on the chest, on your upper chest, and it's supposed to vibrate whenever you are in the right decubitus position and tells you to change it to the left decubitus during sleep time. And this is a study that came from Holland. There are about 4 of them in the literature, all in top papers, showing that it's a miracle device. It can reduces reflux, free nights, decrease nocturnal reflux symptoms, goes on and on. The only thing is that they had 100 patients in this study. At the time they started the study, we served as a second site for the same device. The only thing is, out of 70 patients that we recruited, only 10 finished because the other 60 came to our office 2 or 3 days later and threw the device and says, I can't sleep during the night. It wakes me up every minute. So I don't know why does it work in Holland, but for us, it didn't work at all. And then I thought that was very important because you all know that the PCABs are coming. And the PCABs are, what's unique about them, they have a very long half-life as compared to PPIs. I mean, this is a study with fexuprazan. The half-life is up to 10 hours. Remember, PPIs are only 1.5 to 2 hours. That means we may be looking at this next generation of medications that may address nighttime GERD and sleep deprivation much better than the PPIs that we currently have, just because of their long half-life. So I'd like to finish here and say, never give up on your dreams. Keep sleeping. Thank you.
Thanks so much. That was fantastic, Ronnie. We have time for a couple questions if anyone has them from the audience. Ray?
Unless you're tired.
How strong is the evidence? I'm a hepatologist. I don't think about this all the time. Right versus left decubitus with regard to its impact on GI motility or reflux.
So there is evidence. So that's why it was there as one of those. The studies actually came, the one who did the study was Phil Katz. I'm not sure how many years ago, but that shows that.
Question for the web audience?
Yeah. Oh, to repeat the question. The question was, what is the evidence to support the difference between right decubitus and left decubitus in relation to reflux? And there are studies. So this is one of the lifestyles that we recommend that is based on data clearly showing that the right side is associated with more reflux because of the anatomical position of the stomach in relation to the esophagus. And so there is data to support that.
Yeah, hi, Ronnie. I really enjoyed something I don't read much about. Just the GERD manifestations at night, are there particular phenotypes of sleep disorders? Like there are a bunch of these REM sleep disorders, you lose atonia, et cetera, et cetera. Were you able to tease out, is there a particular, I know you said REM sleep, but I have learned just over the years there's a variety of these disorders. I was just curious if one.
Yeah, and so there are a variety of disorders that I think you're like restless leg syndrome and others, if they've been associated with GERD. Is that what you're asking?
Yeah, did one predominate? I was just curious.
So there are some suggestions, but I don't consider them as substantiated, that maybe GERD is associated with the restless leg syndrome. There's no really, or sleepwalking. There are even, there's even studies that suggested that if you have GERD, you're more likely to have nightmare. So bad dreams, yes. There is a study even suggested that too. So personally, because it was only one and we did more, it's of interest. And when I write on this topic, I mention that. But I think that these are areas where we need more data, yeah. Yeah, Aaron?
Could you kind of reconcile, you showed, thank you. You had showed, I think, a table in the beginning showing that benzodiazepines actually increased, I think, GERD symptoms, but then there was kind of a later table showing that things like Ramelteon, Ambien actually decreased. And so I was just trying to figure out, because they're kind of the same overlapping classes of medications, why,
Yeah.
kind of explaining that difference in findings.
So there are various hypnotics, as you know, and they work differently. Like Ramelteon is not a benzo. It works on melatonin 1 and MT1 and MT2. These are melatonin receptor agonists.
I guess more for the zolpidem.
Yeah,
one,
zolpidem. So zolpidem is mentioned here because there is a data showing that it does work because of the sleep effect. But there is also the same study showed that maybe that drug is not great because it allows patients to sleep through reflux events. So it did not really reduce reflux. It just allows you to sleep through reflux. So I would not put zolpidem high up there. Ramelteon is very interesting. If you'll find, you look at the molecule, it looks like a crude omeprazole, even though it's a sleeping pill. It came from Takeda, so I don't know, maybe somebody saw lansoprazole. But anyway, it works on melatonin 1, melatonin. And there's data that melatonin by itself can affect acid secretion.